Okay, and welcome to the Davies Use Case webinar being presented by Yale New Haven Health on NICU Connected Pediatric Care. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the manager on the Thought Advisory team, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as a vehicle for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speakers for today's webinar from Yale New Haven. We have with us Samantha Harold, Carol Salerno, and Matthew Pizarro and Chris Gutman. And let's welcome them. And thank you for joining us. And I'll turn the presentation over to you. And please begin when you're ready. Thank you.
Harold, Clinical Integrations Engineer for Yale New Haven Health.
This is Carol Salerno. I'm a Clinical Nurse Informatics Specialist working with the Clinical Information Department at Yale New Haven Hospital.
My name is Matthew Pizarro. I'm the Medical Director for the Neonatal Intensive Care Unit at Yale New Haven Children's Hospital.
Hi, I'm Chris Gutman, Director of Clinical Engineering at Yale New Haven Health System. And today we're here to tell you about a project we all worked on and collaborated with the Neonatal Intensive Care Unit at Yale New Haven Hospital in New Haven, Connecticut. We titled this Connected Patient Care because we'll walk you through some work that we did as a group in collaboration on clinical communication systems. At Yale New Haven Health, our vision, mission, and values steer us to incorporate technology and innovate with our patients at the center. And through that, we came to a situation where we were building a new children's hospital within the old children's hospital, kind of a renovation project in which we knew there were opportunities to advance the technologies that better support nursing and caregivers. In the discussion for the construction project, we knew that we were moving from the nursery configuration to private rooms, and that technology would play a very integral part to that change.
So in order to understand where we presently are and how we got there, it's important to have some perspective on where we were. The Neonatal Intensive Care Unit at Yale New Haven Hospital is actually the first dedicated NICU in the United States. It was built in 1960, and the model at that time was very patient-focused. Technological advancements at the time were developing that allowed us to care for more premature babies, but the idea at the time was to house several critically ill babies in one large room so that they could be much more effectively observed and managed. And that trend was adopted in neonatal ICUs throughout the country for the next 50 or so years. So when we sat down to design this new space, we were on a journey to create a premier state-of-the-art neonatal intensive care unit designed with both single and double patient rooms that would provide a more family-centered care delivery system that was safe and ensured the best possible outcomes for all of our patients. So we moved away from the old model, which was very much patient-centered with the family more as observers, to a family-centered approach where the parents became very much part of decision-making and care for their babies. And the other things that we sought to accomplish was we wanted to create an environment that was both quiet and healing, which was incredibly difficult to do in our old environment of large patient rooms with a lot of babies, very noisy, very, very overstimulated, very little space for private conversations and for parent interaction. We wanted our care delivery model to drive technology, and this was an incredibly important piece of the puzzle from the standpoint of a clinician, where we brought what our goals and expectations were to the technology team, and they were able to design systems that fit our goals and not the other way around. And as a result of that, the collaboration was very much interdisciplinary, which is a key component to our success. One other aspect of our unit that we developed that was relatively novel was the idea of couplet rooms, which housed a postpartum mom and a NICU baby together. And this presented a great deal of challenges, both from a workflow standpoint and a technology standpoint, that we were able to successfully overcome. These two diagrams depict floor plans of our old intensive care unit on the left and our new intensive care unit, or one piece of our new intensive care unit on the right. So what you can see is that the old NICU was accommodated a portion of a single floor in our children's hospital, was made up of about 52 beds and encompassed 10,000 square feet. Our new NICU is set up over 2 floors. And in fact, we have a delivery room space on the 3rd floor, so it's really over 3 floors, more than 50,000 square feet, and now 68 beds, including our couplet care beds. And you can see from the diagram that we have both individual patient rooms as depicted by the arrows, and a care team area, so that the medical and nursing care team can be in one aspect of the unit and can still visualize patients around them. But one of the challenges that we faced is in the old system, it was very easy to walk into a room and visualize the majority of your critically ill patients in one particular space. How do we now spread out over a unit that incorporates multiple floors and 5 times the square footage, ensure that we are staying on top of and in touch with issues that are going on that are not directly within our vicinity and within our eye and our earshot? And that's where a lot of the technology came into play.
The previous NICU contained 4 large rooms and a few smaller rooms, and in each large room there was between 10 and 12 babies. When you have that many babies in one space, particularly that many critically ill babies on so many monitors and on so much equipment, if one patient is having a crisis, all the patients experience the sound, the activity, the excitement, and any families who happen to be visiting experience the same thing. And it's a dramatic difference in the space we're in now, but this doesn't have to impact the other 9 babies anymore.
So why the shift from the open bay model first used at Yale New Haven Hospital to private and semi-private rooms? The NICU can be a life-saving environment, but it may also cause long-term physical and psychosocial complications. The exact relationship of long-term complications to the NICU environment has not yet firmly been established, but there is concern that excessive noise in the NICU for a prolonged time can significantly affect the overall health and well-being of an infant. Research has shown that noise levels should not exceed 65 decibels, yet noise levels are reported in some NICUs as high as 93 decibels. Multiple recurring episodes of noise-induced stress reactions can result in apnea and bradycardia, which increases the risk of hypoxic episodes. Loud noise can also increase neonates' heart rate, blood pressure, and respiratory rate, and decrease oxygen saturation. But where does all this noise come from? One huge factor is medical device alarms, and specifically physiological monitoring alarms. Just looking at the data here for 2 months before our new unit went live, we saw 714,000 alarms for December 2017 and 820,000 alarms for January of 2018. Keep these numbers in mind. We'll revisit them later when we talk about our value derived and investments in the system. Some other noise factors or contributors we've identified are the family and staff conversations that had occurred in that open bay model. So to remove the excessive noise, Yale New Haven decided to move to a single and double room setup.
So the evidence showed us that single room design would decrease stressful stimuli, enrich patient and infant interaction and bonding, enhance overall wellness. So how could this design be bad? When the project launched, staff and providers were voicing their concerns about how they would safely take care of their patients. In a pre-move survey, only 27% of the staff and providers were excited to be moving into the single patient room environment. And you can see by these quotes from the staff on this slide. There was genuine fear from the staff and literal tears with the thought of the new construction. This slide shows the open bay room in the old unit. Although very crowded, the staff had the ability to have the direct audible and visual assessment of what was happening in the room, as Matt had pointed out. There was situational awareness and the ability to respond immediately to the needs of the infants, the parents, and to each other. In this beautiful new private room, everyone was separated. How would they know the babies needed help? How would someone know they needed help? And how could they possibly communicate with each other? So to add to this huge transformation, we also created the new model of care, the NICU couplet care, as Matt spoke of. This was a very innovative model where an infant requiring neonatal intensive care treatment is cared for by the NICU team in the same room as a mother who is receiving postpartum care by the obstetrical team. This is a wonderful model of care, as you can imagine, and extremely beneficial to both the new mother and the infant, but created some challenge to the clinical staff. We need to support both clinical teams, obstetrics and neonatology. Each had different medical equipment and different staffing models, and how could they communicate and get assistance when needed by the correct clinical team? It was clear we needed to leverage technology to enhance these workflows in this new environment and support the clinical teams.
Thanks, Carol. As you can see, we had big challenges to overcome and problems to solve. We decided to leverage technology at Yale to solve many of these challenges instead of increasing FTEs or drastically changing the NICU workflows. For new construction and unit redesign projects, there has traditionally been a large emphasis on facilities design and core IT needs. And while those are critical components to budget and plan for, a third important pillar to facility redesign is clinical technology that can be leveraged to solve challenges that may present themselves, such as keeping caregivers connected to their patients' families, and each other in a new environment. What is unique about Yale and this project in particular is that we put the same amount of resources into planning how the technology can support the care delivery model as we did the facility and IT design. We use clinical technology to go beyond standard EMR implementation and bridge the gap between the new facility design and how we could integrate core IT to allow us to move to this new space to provide better outcomes for our patients. We brought higher level technology thinking into the project design.
A key component to the success of this project was our engaged design team. This was a team of 25 interdisciplinary team members, physicians, nurses, respiratory therapists, business associates, business analysts, ITS, and clinical informatics. This group was very dedicated. Our first step was to provide baseline education, and then we utilized simulation and workflow review to understand the changes from current state to future state with connected care. We called it Care Delivery Reimagined. This hands-on approach created a group of champions that supported the adoption through to the implementation process. The design team identified 3 key areas of workflow: staying connected to the patient, staying connected to the family, and staying connected to each other. We asked focused questions to understand what was happening today. Who needed to be contacted? What information would they need to know? How fast would they need this information? How fast would they need to react? And how would they need to respond? Once we understood the information that would need to flow in each of these situations, we reverse engineered the technology to meet these needs. We then simulated these workflows in the real environment. These were the high-level milestones of the project: the engaged design team and the use case-driven workflow, which I spoke about previously. User acceptance testing, this is where we verified workflow decisions. Adoption-focused training, the training was hands-on and done in the real environment. It focused on workflow changes and not so much the details of the technology. Primary focus was on how to safely take care of the patients, address family needs, and get help from their team when needed by using the new technology. Commission testing, there was a committed 5 to 6 week process and a joint effort between consultants, ITS, and clinical engineering, testing all devices, alarms, and workflows. And then active go-live support. It was very important to the team and the staff to have active go-live support. This provided reassurance that issues, if any, would be addressed quickly. There was 3 days of 24-hour on-site support.
Yale New Haven made some significant investments in clinical technology to provide the right information to the right person at the right time on the right devices. Clinical engineering and the integrations team performed a gap analysis to determine where our technology was and where it needed to go to support the NICU's workflow. We purchased a new nurse call system for the NICU, as well as brand new isolettes to account for all of the new rooms and beds. We identified the need to upgrade our physiological monitoring system, and we'll talk a little bit more about the logic behind that, again, when we talk about our value derived. We upgraded our infant security and elopement system, but we also identified new ways to utilize existing technologies like Capsule and Epic to get ventilator alarms and patient information distributed to mobile devices. Our biggest investment, however, was our middleware software, which takes in all of the information from these disparate systems and distributes the alarms, alerts, and communications to smart mobile devices, which were also new to the NICU team. Bringing all these systems together to deliver alerts to our clinicians, shown here on the right-hand side of this diagram, challenged the team to understand different communication protocols and any possible limitations. One such limitation, for example, was that our brand new isolettes did not have the ability to output discrete data, which was a known and accepted limitation. But the team was still able to integrate through our nurse call system, which then utilized a SIP-to-TAP gateway to send information onto our middleware and onto our mobile devices. On the top left here, we connected our physiological monitors with a direct HL7 connection. And as mentioned, we found another use for our capsule machines. They were already installed on all of our ventilators for Epic integration, but now we could send that same information onto our middleware software. Our infant security system connects a different way. It sends notifications to an email recipient. Those messages are monitored by our middleware software and send those alerts to our clinicians as well by pulling them from the transmission process. Once we got all of those systems connected and sending data, the clinical engineering and IT teams spent a significant amount of time mapping variable IDs, configuring filters based on those IDs, and setting up the alarm message displays for what clinicians would actually see on their mobile devices. Speaking of what the clinical users would actually see, here is the middleware user interface. Staff can assign bed and room level coverage for nursing and respiratory therapy, and floor department level coverage for some ancillary support roles. These middleware clients are available on all clinical PC thin clients in the unit, which further fostered collaboration between the different IT teams and the clinical engineering team. Users log in with their network ID thanks to Active Directory integration and select their name from the user pool. On the left-hand side of this page, users would drill down in the institution topology to their role and bed in the patient room. Users would then drag and drop themselves into the assignment and save. Alerts are configured to send to a role, not a specific user, so whoever is assigned to a role will receive the alert in that escalation path. So let's run through some scenarios. Here is our head wall design that is standard in every room. Highlighted here In blue are our medical equipment jacks, which are part of our nurse call system. The jacks will trigger dome lights outside of the patient room to assist in visual directional cues, as well as some system redundancy. When a physiological monitoring alarm is active, let's say a bradycardia, the monitor alarms in the room as well as at the central station, but also a pink and white dome light is illuminated and an HL7 message is sent on to the middleware for distribution to the nurse's phone. The middleware determines this alarm needs to go to the primary nurse assigned to the room, and so a message is sent with the room information. The nurse then has a few options. They can call back into the room to see if any other caregivers could assist. They could escalate the alert if they were busy with another patient, or they could accept the alert, which means they take ownership of the alarm and head to the patient's room to address. If the primary nurse gets to the room and identifies the need for a backup nurse, they can hit the backup button on the staff terminal, which will trigger a red dome light outside of the room and send a message to the nurse assigned as that backup role for that room. And I just want to call out here that the design team identified the staff terminal as a one-touch communication tool and installed in the head wall, which deviated from the vendor recommended function of this feature, which was quote-unquote room registration. Anyway, so that backup alert triggers the dome light and the message is sent out. One last example incorporates our providers. When a code is called, a completely red dome light is triggered outside in the hallway, and a notification is sent on to our provider's phone. Note how they no longer have a call or escalate option. They were trained by our wonderful training staff, and they are expected to respond just to a code alert. There was also some technical limitations regarding calling because providers have personal cellular devices and could not call back directly into the network device.
So here's a workflow example of staying connected to the care team. In this case, the ventilator is alarming. The ventilator has been assigned to this patient using barcode scanning and the Epic ADT feed. The capsule sends HL7 messages to the middleware, and the alert with the appropriate ventilator message is sent to the nurse's mobile device. Knowing that she needs respiratory therapist assistance, she can select RT Assist button on the staffing station, and this will send an alert to the RT mobile device, and if the respiratory therapist is unable to respond, it will be sent on to the secondary responder or the backup RT after a defined amount of time. This is a picture of our custom designed pillow speaker that can be used by the families to get urgent and non-urgent assistance when needed. So for an example, if a parent selected the heart button, this will send a non-urgent RN request alert to the RN assigned to that patient's room. The RN has the option to accept the alert, which means they're taking responsibility of responding to the request. And if the RN is unable to respond, they can select Escalate, which will automatically send the alert to the secondary or backup RN. Or they can select Call, which opens up the intercom in the patient room to allow for verbal communication.
So what is our value derived of this project? We did end up with a calm, quiet, healing environment. In fact, data supports that we have reduced our length of stay, decreasing it from 23.9 days in 2017 to 22.1 days in 2018. Some major contributing factors to that are, of course, the significant noise reduction in the patient care areas by moving to those private rooms, but we also have seen a drastic reduction in the quantity of alarms in the unit. One of those other contributing factors we had talked about was family and staff conversations. So now that families have their privacy, those conversations happen behind closed doors and do not disturb other families and patients. Families are comfortable and they can reach help when needed. A quote from a post-go-live survey directly from a family states, "It's fantastic to have a private room. Good balance between having an RN in the room and being able to have family time." We see that our babies are sleeping more, They're healing, it's quieter, it's calmer. In fact, our cuddler staff are constantly looking for things to do because we don't have fussy babies as often anymore. So I want to drill down into the statement I had made on the last slide about the drastic reduction in the quantity of alarms that we have. As I had mentioned earlier in the presentation, we talked about those overwhelming quantities from December of 2017 and January of 2018. A year post-go live, we've seen a 70% reduction in those alarms, thanks to the newer technology, smarter alarms, and the critical thinking of the design team. We were able to create alarm parameter profiles based on the patient's gestational age as well as the percent of oxygen they were in. So we are customizing alarm parameters based on the actual individual patients. Some other contributing factors, again, just the new construction. The alarms don't startle the other patients, so we're reducing unnecessary stimuli. With the investment in the new physiological monitoring system, we are able to remove red latching alarms. So if the patient triggers a red alarm but the condition self-corrects, the alarm shuts off without any nursing intervention. We also contribute the fact that, yes, the nurses were in close proximity in the old unit, but they would occasionally be outside of the bay. So now we have secondary alarm routing for faster response to alarms. All of this has led to the reduction in alarm scene, which we know reduces nursing and physician burnout. And we have worked really hard to be cognizant of the alarms generated and triggered that go to our mobile devices. In fact, our design team decided to only send red alarms on for secondary notification to those mobile devices. I just want to highlight some data now to discuss our proactive interventions from that one-touch communication tool, our staff terminal located on the head wall. Those buttons were really designed to be proactive interventions in mind. So those buttons would be hit to notify other members of the care team to attend to the patient before their condition worsens to code level status. So we're trying to de-escalate the situation. And we have seen great use of our RN primary assist and our RT primary assist to get the primary nurse and primary respiratory therapist into the room before the patient gets to code level status. We want to point out too that it's important that our caregivers can contact our med team staff as well as the triage nurse in the event of medical attention before the patient again gets to that code level status. And in fact, we've seen very little code activity for either NICU codes, our baby codes, or our YOCA codes, which is our Yale on-call attending code for our mothers in our couplet care room. We actually had 4 months last year where there were no code events at all. And with that, I will turn it over to Dr. Bizzaro to talk about some value derived for our couplet care.
So we also recently compared data from our couplet population to a control population that were babies derived from our prior NICU space that would have met criteria for being in couplet care. And we wanted to determine whether or not some of the clinical goals that we set out to achieve with this model were actually achieved. So when we looked at 244 babies in our couplet population and compared them with 346 control babies, we did see a significant increase in the percent of babies that breastfed in our couplet model, so 92% compared to about 83%. Although the difference was not statistically significant, we did see a dramatic improvement in the time to first breastfeed by almost about 3 hours. You can also see a statistically significant reduction in length of stay, and we think that by having the family and baby housed together and part of the care team and the transitional plan, it greatly facilitates that movement from the ICU to home, which is likely responsible for some of these findings. So our new NICU and the technology and innovation that it incorporates has actually gained some local and national recognition, particularly as it pertains to our couplet care models. You can see some headlines from some publications, including our being named by Parents Magazine in 2018 as one of their 20 top children's hospitals in innovation and technology.
We really appreciate that recognition, and it really goes to show from all these lessons learned across the groups how the collaboration brought it together. So in trying to wrap this up, we did see that executive sponsorship and the vision from the top, and not just making a new children's hospital, but also incorporating technology to help with some of the physical changes and adjustments that were being made was important. The team commitment, I don't think this could be overstated enough. The amount of team members, the 4 of us are here to represent and give this presentation, but literally ends up translating to hundreds of people getting involved all the way through construction, vendors, the nurses being trained on the floor, subject matter experts stepping forward to be real people of excellence in working with the technology, to workflow changes, to the business associates in the front of the unit, taking the information and helping with scheduling. It is a daunting task to move from what Matt explained at the beginning, is that open bay concept where everyone could see each other and be very comfortable with non-verbal cues of alert and alarm, and now having to translate to a pure technology approach was quite a challenge and took a huge team effort. The timeline, I think it was good and bad that the timeline helped the group to come together even more tightly, because they knew that we needed to get it done by a certain timing for the improvement of the spaces while construction was happening and while we were able to do it. So that was really fantastic to see the group come together and rise up to the challenge of the timeline. And the vendor assimilation, I think we all know in healthcare that it can be challenging and rewarding when we can have vendors really step up and partner with us as an organization and align to the vision, not just selling products, but truly actually trying to achieve goals that we are in patient care to improve our patient experiences. So all 4 of those portions of what our lessons learned are probably the 4 cornerstones to what made us able to drive and achieve what we did.
Okay, and we would like to thank our presenters from Yale New Haven for joining us and sharing their Davies stories on the NICU connected patient care. And we'd like to remind our listener where to go find more Davies use case webinars and information on how to apply for Davies. Information can be found posted at the HIMSS Davies Award website at hims.org/Davies. That is hims.org/Davies. Thank you. Thank you for listening.